Muy buenas noches a todos. A nombre del Colegio Mexicano de Otología, Neurotología y Cirugía de Base de Cráneo, les damos la más cordial bienvenida a nuestra sesión mensual, que para nosotros es el cierre de nuestro año académico, ya que iniciamos en febrero y terminamos de esa manera. Esta noche tenemos la presencia de un invitado extranjero que nos dará una plática de reflexión sobre lo que es un tema muy interesante como la otoesclerosis. El doctor Ronen Nazarian estudió la carrera de medicina general en la Universidad de California en Los Ángeles. Posteriormente emigró al otro lado de Estados Unidos, hacia el estado de Florida, para hacer la especialidad en otorrinolaringología, posteriormente en otología, neurotología, y regresar a California, donde se encuentra actualmente, que es director del Centro de Otología y Cirugía Avanzada de la Audición en Beverly Hills. Es adscrito al Hospital de Mount Sinai en ese mismo lugar. Pero más que todo esto, es un apasionado de la otología, de la reconstrucción, y en esta parte en particular tuvimos la oportunidad de conocerlo el año anterior con esta plática que queremos compartir hoy con ustedes sobre algunos aspectos de la historia del manejo de la otoesclerosis, particularmente de la parte quirúrgica, hablando sobre los pioneros en este tema. Hemos escuchado sus nombres varias veces, los hemos visto en los textos, pero quizá no imaginamos lo que tuvo que pasar para llegar a los procedimientos de reconstrucción del estribo, de manejo del estribo en esta patología, lo que tenemos actualmente. Doctor Nazarian, welcome to Mexico. Welcome to our monthly session of the Mexican College of Otology, Neurotology, and Skull-Based Surgery. It's a pleasure to have you here, and it's your time. Go on, please.
Thank you so much for having me. And I really want to thank Dr. Leon Felipe Garcia for having me and the whole Otology Society of Mexico. This is a great, great honor that I get to share not my story. This is our story. And I hope that you guys can share our story with everyone else, especially your students. This is a story that impressed me, and I hope that it will impress you. And I say the story many times a year, not just in talks, but also in the operating room to my students. It's just an amazing learning experience. So I will talk to you about otoesclerosis surgery. I'm sorry, puedo hablar español, pero no soy muy fluente, entonces voy a hablar en inglés para esta presentación. Pero si tienes preguntas al fin, puedo contestarlos en español, si es posible, y también puedes llamarme cuando quieres para hablar, o si quieres visitar a Los Ángeles, estoy aquí. So, why did I pick this topic? Why do I love this topic? I always loved history. And I really believe that by looking at history and looking at the past, we can predict some things about our future. And this talks about otosclerosis, but I have other historical talks. For example, the history of cochlear implants, which maybe I'll give to you guys at another time. But today we're going to focus on otosclerosis, and I even have a book chapter that we published. And if you want to look at it in more detail in the Otolaryngology Clinics of North America, you can look up that paper, or I can send it to you. But really, this is our story as otologists. This is our story for universally. Every country has its story, every group has its story, every tribe has its story, and as otologists, this is our story, and we should be proud of it. I used many different sources to get this material, from review papers to oral histories, videos from surgeons before us. There was a lot of material from the House Ear Research Institute here in Los Angeles, also from Howard House's, one of the fathers of otology, His own biography had a lot of information about these stories, and also from the American Historical Archive, and even from the Oto Museum in Brazil. There were some of these videos are shared from that museum. So as you guys know, otosclerosis, we all know what it is and what the pathology is. It involves the stapes, but really we're not here to talk about the pathology of otosclerosis. We're here to talk about the history of, and how all this started. And believe it or not, otosclerosis has been treated surgically since the 1800s, but it was lost and brought back and rediscovered in the 1960s to have modern day otosclerosis surgery that we know of today. So I'm going to go back all the way back to the history, and many things have changed since the 1800s. As you can see here, our techniques, the types of prosthesis, lasers, and everything else that we use has really changed in the modern day. This is a timeline that I'm going to follow. As you can see, even from the 1800s all the way till today. This timeline is present in the article that I published, and you guys can take a look at that if you want to later on. So I like to divide the history of stapes surgery into 4 time periods. And these are the time periods that we have that is known in the literature that we treated the process of otosclerosis. So I divided into the pre-antibiotic era, which is from the 1870s all the way to the end of the 19th century. The fenestration era from 1913 to 1952. This was spearheaded by Dr. Julius Lempert, as you guys might have known or heard the name. The mobilization era, that was spearheaded by Dr. Samuel Rosen for just a short period in the 1950s. And then we have the modern day stapedectomy or stapedotomy era. Okay, and I'm going to talk to you guys about each one of these eras. Each one of them is interesting in its own. So before we get into the surgery, I'd like to just mention that people knew about otosclerosis from the 1700s. The famous Valsalva actually described in 1704 the first known case of stapes fixation as a cause for hearing loss. Now, you guys have to imagine how he even realized that. Back then we had no microscopes, no otoscopes, no way to magnify. People were just looking at an ear with a backlight and a mirror. People were looking at this with their own eyes, or either on a live patient or through cadavers. But this was the first described case of a stapes fixation as a cause of hearing loss. Toynbee in 1841 also described a chronic inflammatory mucosal change in the middle ear that resulted in secondary ankylosis of the stapes. And in 1893, 52 years later, Politzer, another famous otolaryngologist, he dissected 16 cadavers with stapes fixation, and he described this disorder of the labyrinthine capsule, and he actually named it. In 1893, the name otosclerosis was coined by Dr. Politzer. So I want to talk more about the pre-antibiotic era. This is such a miraculous thing that happened, that there were surgeons operating on the stapes in the 1800s, and basically the surgery was banned and forgotten, and then rediscovered again by John Shea in the stapedectomy era. But a lot of things happened in between that, the pre-antibiotic era and the stapedectomy era. So the pre-antibiotic era in the late 1800s, I believe, was when some of the boldest surgical advancements were made. This surgery was soon abandoned due to concerns of long-term efficacy and also due to patient safety. And I'll explain exactly what happened during this time. So the stapedectomy era, we can say that in 1842 was the first known case where Meniere in France described that a live patient's hearing improved when he tapped on the stapes directly with a golden rod. So probably what happened when he did that, he mobilized the stapes, and they realized that they were able to mobilize it and recreate the ossicular chain and bring back hearing. Almost 30 years later, Kessel in Germany first tested this with pigeons, and then he began to do this on humans, where he actually made an incision directly through the tympanic membrane, not like how we do it today, where we lift the tympanic flap. He actually made a posterior tympanic membrane incision, saw the stapes, mobilized it, and was able to restore hearing. And he publicized this as the transtympanic stapedectomy. And in some cases, he would mobilize it, but in other cases, he would actually remove the whole stapes and then let the eardrum basically sink back onto the footplate and to create like a type 4 tympanoplasty. And that would restore hearing in a lot of patients. So in this pre-antibiotic era, hundreds of cases were reported, but they were lost in the medical literature, and they weren't rediscovered again for over 50 years. So like I said, there was no tympanic flap. You have to imagine these surgeons, how talented they were. They were not using any magnifications. They barely had any light. And they just let the tympanic membrane sometimes heal over the oval window. They were not using any sealing of the oval window like we do today with fat or fascia, and they were not using any prosthetics. So they were basically either mobilizing the stapes or removing the stapes in its entirety, but not really putting anything there like we do today with a prosthesis to restore the ossicular chain. And I think this is just amazing. So obviously, there were complications. As you know, penicillin wasn't discovered until 1928. And these surgeries in the pre-antibiotic era were done between the 1870s to the 1890s. So there were a lot of complications. Even though the surgery was successful, some patients were getting labyrinthitis, which was sometimes even fatal. It would cause meningitis. And in some patients, because the stapes was just mobilized, it would only cause a temporary improvement. So in 1899, the 6th International Otolaryngology Congress declared that stapes surgery is useless, dangerous, and unethical. And stapes surgery, any surgery on the stapes, was banned. Dr. Kessel, who was the founder or the pioneer of this surgery, he was condemned. All his followers were condemned, and he resigned in disgrace and never treated a patient again and just did research for the rest of his career. So this was a big deal. Even though the surgery was pioneered in this era and people were making some amazing advancements, because there was no antibiotics being given during these cases, there were a lot of complications, and the International ENT Society basically said that you can never touch the stapes ever again. Okay, and the surgery was basically lost, and people forgot about it. And for maybe 2 generations or 3 generations, the surgery was basically forgotten. So what did people do? I mean, otoesclerosis was still a very significant pathology. And back then, otoesclerosis was the most common reason for hearing loss, not like what we have today. So there were lots of patients with hearing loss due to otoesclerosis, and now it was prohibited to do any surgery on the stapes. But the problem still existed. So what do we do? To avoid any type of stapes manipulation, almost accidentally, we figured out that there can be a third window that can restore the hearing when patients have otosclerosis. So why is that? So basically, if the oval window is now affected by otosclerosis, there's only a one window system, right? Like the round window. So one time accidentally in a mastoidectomy, the semicircular canal was accidentally fenestrated. And what they saw was that hearing in patients with otosclerosis significantly improved, because what it was doing essentially was it was creating back a one window system into a two window system. Okay, and that was creating basically a third window, like how we have when we have a superior semicircular canal dehiscence. So through this third window, transmission of sound waves were being able to be transmitted into the perilymph, and that was restoring the hearing. So I'm going to talk about this, and this is what created the fenestration era. So nobody was operating on the stapes, but now the fenestration of this lateral semicircular canal was bringing back hearing for a lot of patients. So who pioneered this? It was Dr. Holmgren in the 1920s. It was done, like I said, by accident during a mastoidectomy surgery. And when he saw that this was happening, he created a three-stage fenestration of the lateral semicircular canal. And it was the technique was a closed fenestration. But then the surgery was very complicated, and not everyone could repeat the surgery that Holmgren was doing. But what happened is Dr. Sourdil in France, he watched Holmgren, and what he did, he still kept it as a three-staged operation, but he went post-auricularly, and he made it into an open procedure, meaning that if you can imagine like a canal wall down mastoidectomy, but the graft that we put at the end would go on the fenestration on the semicircular canal, and that would create the third window, but in an open cavity, like a canal wall down mastoidectomy. And Dr. Sourdil called this the tympanolabyrinthopexy. And it had a pretty good success rate. It had a 64% success rate in restoring hearing. And unlike other procedures, it was long lasting. So Sourdil became very famous, and he was giving talks all around the world for his technique that was restoring hearing for patients with otosclerosis, almost 25 years after the stapedectomy operation was banned and forgotten. So in 1937, Sourdil was invited to address the otolaryngology section of the New York Academy of Medicine. So when he came to that meeting, someone was in the audience, and that someone was Dr. Julius Lempert. And Julius Lempert, just by listening to Sourdil, ended up revolutionizing the fenestration operation. And here's an old video. This is Dr. Sourdil, as you can see, gentleman doctor who came to visit. And then we have Dr. Julius Lempert, very quirky looking doctor. But Julius Lempert really became an inspiration to us all. So Julius Lempert, I'm going to just focus on him for a little bit because his story is miraculous. He took Sourdil's operation and he developed it into the single stage end oral fenestration, meaning that he, instead of going post-auricular, he was doing everything through the ear canal end orally, and he was able to create the mastoidectomy and create a fenestration that was open. Julius Lempert, even though he was very innovative, he was hated by many. He revolutionized otology. He introduced instruments that we still use today, such as the drill. He introduced the operating loops to the operating room. He also was the first to use a headlight in the operating room that we still use today. And he was the first otologist to create a temporal bone lab where he was teaching other otologists and students his famous technique. So what Julius Lempert did would be an impossible accomplishment in the 21st century. but still his story is inspiring to all of us, and it should inspire all of you if you don't know his story yet. Julius Lemper was born in Poland. He was born in a Jewish ghetto. He was Jewish, and he moved to New York City in 1905 because there was a lot of unrest in Poland, and his village was attacked by the Cossack army. He was a small child. He wasn't very tall. He would get bullied, and even when he was a kid, there were stories that he would pay for protection. In 1913, he went directly from high school to Long Island Medical School. Back then in the US, there were Jewish quotas, meaning that Jews were not allowed to go to any school that they wanted. They definitely could not go to first tier medical school. And there were limits on how many Jews were able to go into a certain school. So it's very well known that in the US during this time, there was a lot of discrimination against Jewish doctors. So he went to Long Island Medical School, which was the school that he was able to get into. It was considered a third-rate medical school. Because it was a third-rate medical school, he couldn't obtain an internship anywhere. And he wanted to do ENT. He wanted to learn ear, nose, and throat, but he wasn't able to get into a residency from that medical school. So what did he do? He wasn't able to do residency. So he decided to do a residency for himself. So what he did was he went and visited different programs in New York. And he just went there as an observer. He went to the Manhattan Eye and Ear Infirmary. He went to Mount Sinai. He went to Columbia, and he went to NYU. Just as a visitor, he would go there and just watch the surgeons do what they do. In every single institution, for one reason or another, he was asked to never return by any of them. He basically outstayed his welcome, and he was kicked out of every single place that he was observing in. So he decided to open his own office, and this was done in Greenwich Village. He was a notorious fee splitter. What does that mean? Well, these days now it's illegal, but basically the way that he would get patients is he would tell doctors, referring doctors, that he would give them 50% of the money that he made from each surgery. He would give back to the referring internist or whatever doctor send him a patient. So he immediately became not only the most busy ENT surgeon in New York, but also the most hated surgeon in New York, just because doing that was unethical. He would do 100 operations a week, and he practiced assembly line surgery, meaning that he would line up the patients and would do various surgeries like tonsils and adenoids, septoplasties, and also little by little, he would do more and more radical mastoid procedures for chronic ear disease. And I just want to show you guys, when I'd say assembly line surgery, this is how fast the surgeries would be done back then. This is an example of what a tonsillectomy and adenoidectomy looked like back then. I'm going to play you the video. So you can see the kid getting ether. This is ether. They would inhale it. The patient would be half awake. They do a cold removal of the tonsils. You see all the bleeding here. They would remove the second tonsil, and this is how they would do the adenoids. As you can see, very different from how we do it now. No intubation. And that's it. Tonsils are out, adenoids are out, and the patient is sent back to recovery. I love watching this video. So that's how he would do it. So soon, Julius Lemper became very rich. He bought a Cadillac limousine, and he had a chauffeur who would take him all around Manhattan. All his friends were in Broadway and in show business, and he even began to finance Broadway plays and musicals and everything else. And he even married a Broadway star who was a lot taller than him. So Julius Lemper was only allowed to operate at the Manhattan Eye and Ear Institute. And I want you guys to think about what was going on back in the 1920s. Mastoid surgery was only being done with a chisel and mallet. Okay, so imagine using a chisel to do the mastoid. What that would do is a lot of the patients would get inadvertent facial nerve injuries or tegment injuries because the chisel and mallet is not that exact. So Julius Lempert said that he wanted to try the dental drill. So he went downstairs, he went to the dental office, got the dental drill, and brought that into the operating room, and he wanted to perform the mastoidectomy with a dental drill and not with a chisel. What happened was the head nurse of the OR was horrified. She couldn't believe that he was using a dental drill to do a mastoidectomy, to do ear surgery. She called the chief of surgery right away, and Julius Lempert was asked to leave. He wasn't even allowed to finish his own case, and another surgeon finished his case. So, now looking back at it, he was actually right. The drill is the better instrument. But as you can see back then, his innovation was considered outrageous. But imagine if we were still doing these mastoid operations with a chisel. It's just crazy. And I want you guys to see a video of how that operation was being done. You can see here the incision, the postauricular incision, the mastoid, and you see the chisel right there being used to create the mastoidectomy. Now imagine how many patients got inadvertent accidental injuries. You can see here that's the posterior canal wall being shaven down. You can see here they took out the incus. And then the skin will be closed and packed. Really amazing videos to watch. So again, Julius Lempert was not allowed to operate in any of the city's hospitals. So what did he do? He opened up his own institute for endoral surgery, and he started doing more and more ear surgeries, and he focused more on ears and creating his own fenestration operations. He would do hundreds of mastoid operations in this hospital. So during the surgeries, he not only continued to use the dental drill, but he also brought in a headlight because he believed that there was not enough light from the overhead lights. So he created the first headlight that we still use today in surgeries. And he was also the first surgeon to take jeweler's loops and use magnifying loops during the surgery to create the fenestration operation. All other surgeons continued to use the overhead light, and they were not using any loops. And this was obviously before we had microscopes to do the surgeries that we do today. He also became very famous in making some of the first surgical videos. And here is the video of him creating the fenestration operation that I was telling you guys about. So you can see here, he's the one not wearing a mask. He creates an endoral incision through the concha, and he accesses the mastoid by removing the conchal cartilage. So the conchal cartilage is removed, and now he's using the dental drill to create the mastoidectomy through the endoral approach. After he drills the mastoid, he finds the semicircular canal, and that's when he puts on his loops. You see the loops. He adjusts his headlight. Remember, we have no microscopes at this time. And this is when he makes the fenestration. And you can see the little fenestration in the semicircular canal. And that creates the third window effect. Then he would take off the loops, and then he would take the skin flap and place it over the fenestration. So that skin flap would heal just like a canal wall down mastoidectomy. He would pack that, and he was done. And this is him in his office examining the patient. This is a big painting of his son who died of leukemia. And that's the endoral opening there. I still to this day have some patients who were operated on by Lempert. This is a CT scan of a patient of mine who had the Lempert's fenestration operation, and you can see that right there, the fenestration that they made in the semicircular canal. So what happened? Lempert was innovative. He made this operation that was very successful. However, because he wasn't board certified, he couldn't really publish his results. So everyone in New York and outside of New York knew about Lempert and what he was doing, but he never made it official to publicize his work in any journals or in any meetings. So there was this guy, Kopetsky. Kopetsky was an ENT surgeon who was still recommending hearing aids for all his patients and not doing any surgeries. Kopetsky decided to visit Lempert. And after he saw Lempert working for a while, he suggested that they should report the work at the next coming meeting of the American Otologic Society. Kopetsky was a member of that society, but Julius Lempert was not. And obviously, the AOS membership is by membership, by invitation only. So Kopetsky said, let me present it and give you credit for it. So Lempert was very excited, and he allowed Kopetsky to take all the results and present this at the meeting. So Kopetsky presented Lempert's work, but he did not give any credit to Lempert. Now, people were in the audience, and they knew that what Kopetsky was presenting was actually what Julius Lempert was doing. So an emergency meeting was called immediately, and Kopetsky was terminated on the spot, and they decided to finally allow Lempert to publish his paper. And in 1938, Lempert was able to report 23 cases of his fenestration operation, and Lempert went into history at this point. After 1938, when everything was published and he became world famous, he had a constant stream of ear surgeons visiting him. Because of that, he created the first temporal bone course to teach all his students how to create the fenestration operation. He gave 2 courses a year, and back then, in the 1930s, he would charge $2,000 per course. Even today, that's, we're paying $2,000 for some of these courses, and that's a lot of money. Imagine back then paying $2,000 for the course to learn the fenestration operation. So the students would work in the lab and observe him in the OR. At the end of each day, he would take them out to dinner, and then he would hand everyone Cuban cigars. All the employees would line up, and he would give each one of them a $20 bill. And this was at the height of the Great Depression. So Lempert was a little bit of a show-off, but he was an innovative guy and very misunderstood. So really, what I want to just take a moment to think about Lempert's work. He never had an official ENT residency, but he was able to learn and create this fenestration technique, and he was eventually given credentials by every single prestigious academy, including the American Board of Otolaryngology, the American Academy of Ophthalmology and Otolaryngology, and even the Triologic Society. Really, he, what he did with his life, with nothing, he turned it into everything. So now I'm going to go into the mobilization era, and I'm going to talk to you guys about Samuel Rosen. And Samuel Rosen was actually a student of Lempert. Samuel also grew up in a poor section in Syracuse, New York. They were very, very poor. His brother and sister put money together to pay his tuition at Syracuse University. He wanted to study law, but then he went into medicine, and that's Samuel Rosen there in the video. So Samuel Rosen was pretty famous, and he decided to learn the fenestration technique from Lempert. Lempert, from the very beginning, never liked Samuel Rosen. And from the moment they met, the people said that the two men were like oil and water. When Rosen wanted to watch Lempert operate, Lempert would try to block his view and not let him watch. Lempert did not like Dr. Rosen. But Rosen, almost by accident, again, figured out during a fenestration operation, he figured out that by accident, he mobilized the stapes and the patient was able to hear. And that's what created the mobilization era. And here is Samuel Rosen, many years later, talking to Dr. House about how he figured out the mobilization technique. Here you go.
Sam, would you like to tell us a little bit about how this all started? You were the father of it, and let's hear your story.
I'm beginning to feel like a grandfather. But it was in 1952 that I decided that I would like to lift up the eardrum and test for mobility of the stapes, since at that time, after I lifted up the eardrum and exposed the incus and stapes, and I was testing to see if that stapes was mobile. It wasn't mobile, but I wasn't sure how immobile it was. So I just kept on doing it 2 or 3 times. And suddenly, he said, "Doctor, I can hear everything." I whispered to him, "Can you hear me?" Very soft whisper. And he said, "Are you yelling?"
So the patient said, "Are you yelling?" So Rosen still couldn't believe it. After he did the first patient by accident, he couldn't believe it that this actually works, because as you know, the stapes operation was long forgotten. So he practiced this on 100 cadavers before trying it again on a live patient. And when he published this work, again, just like Lempert, his colleagues were all skeptical and furious. It was a relatively simple operation, right? You're just lifting up the tympanic flap like we do today, and you mobilize the stapes. And compared to the fenestration operation, it was a very, very easy surgery. And just many surgeons who were doing the fenestration didn't believe it, and basically said that Rosen was lying. So what would happen, as we know today, is Rosen, when he mobilized the stapes, a lot of times the stapes refixates. So after a few months or even a few years or sometimes even a few weeks, even though the stapes is mobilized, it soon refixates. And that was a problem. But Rosen a lot of times would take patients in 3-4 times back into surgery to do the mobilization. And for about a decade, this was a popular technique. And many other doctors were doing that. They were mobilizing the stapes. But no one dared to actually remove the stapes and replace it with a prosthesis. Not until Samuel Rosen came into the picture. And here is Samuel Rosen. And what he did in 1956, almost over 50 years after the stapedectomy was outlawed and forgotten, Samuel Rosen brought back the stapedectomy into what it is today. So, sorry, what I was trying to say is John Shea, not Samuel Rosen, John Shea. So John Shea studied under Rosen in 1953, and Rosen recommended for him to go study in Vienna, because back then Vienna had a lot of cadaveric work, and their research for otoesclerosis was very big. So John Shea went and traveled to Vienna, and by accident he went to the library in the hospital, and he found this paper from the 1800s. He saw a paper from Frederick Jack from 1892 that was describing a case report of a double stapedectomy that was done in the 1800s, and it was describing how the patient was hearing again. So when John Shea read this paper, he got an idea. He said, obviously the mobilization technique works, but it's flawed because of the refixation. So John Shea modified the procedure, and he decided to perform the stapedectomy, where he would remove the entire stapes, and instead of it, he made this Teflon prosthesis that kind of looks like a stapes. This was the first ever stapes prosthesis made out of Teflon. And what he did is he put that to reconstruct the ossicular chain. So he was able to appreciate the stapedectomy operation that was done in the 1800s, but he also appreciated the flaw that what they were doing was they were just removing the stapes and just letting the flap sit back on the oval window. So what he thought about doing is creating this prosthesis. And obviously, this is not the same type of prosthesis that we use today, but this was the first prototype, and it worked. So now, John Shea started getting famous. People started talking about his technique, but it was not published yet. And honestly, John Shea was very worried about publishing or presenting his work, because he saw what happened to Julius Lempert. He saw what happened to Samuel Rosen, and they just didn't know how to bring this out to the public and to the rest of the doctors across the country or across the world. So Howard House, who was a gentleman surgeon and knew John Shea, encouraged him to present his work at the next Academy meeting. Both of them knew how the audience would be highly critical. So Dr. House had a plan for this. And you can see with his own words what his plan was.
Well, knowing what Lempert had been through and knowing what Sam was going through with all of these obstacles and critics and so on, I recall so vividly saying, let's get this in the literature, John, because it is revolutionary. Good, bad, or indifferent, we should have it. And if you sent that in for publication in those days, you wouldn't have a prayer having it published. No. And so I remember after this, about an hour and a half of mobilization, discussions, and presentations by the panel, we had about a half hour left for questions from the audience, and a large audience at this meeting, and it's due to stop at 12 o'clock. And I said, now, John, I'm going to ask for questions from the audience, and they can come up and discuss over the microphone so everyone can hear them if they like. But in your case, I'm going to about 3 minutes before 12. I said, it's time for one more discussion. Remember that? I do. I looked over, you raised your hand, and I said, Dr. Shea. Here this young fellow comes up there on the podium, and presents his case, showed the stapes, and showed the audiogram. And I'm sure there must have been 20 little slips of paper running up to me from the front row and the second row. I must discuss this paper. I can't let this be said without saying something about this. This is terrible, in essence, And I looked at my watch, I remember very, very serenely, and I pounded the gavel and I said, gentlemen, I'm terribly sorry. There's many more questions. Many more would like to ask questions about this presentation this morning, but the time is up. It's exactly 12 o'clock, and I pounded the gavel. But John, we got that in the transaction. That's right. Remember? I do, Howie. Now I appreciate that. That was an interesting time. And from then on, of course, it's quite history.
So really, Dr. House recognized the Shea's work. And even though he knew everyone was going to be critical, he recognized the importance of his work. And he was such a gentleman to let John Shea present his work at the very, very end of the meeting. And Dr. House was the president at that time. So basically, John Shea presented the work, and nobody had time to criticize it. And that's how they got it published. And the rest is history. So during all this time, Lempert was still operating, Rosen was still operating, and now John Shea, this young guy in his 30s, came up with the revolutionary stapes operation. And John Shea's operation was getting more and more famous. There was Rosen was still doing the mobilization technique, and Lempert was still doing the fenestration technique throughout this time. Lempert never changed his ways, even though there was obvious effect of the stapedectomy operation. Lempert never changed, and until the very end of his career, he was still doing fenestration operations. And Rosen did the same thing. Rosen never changed his ways, and he was doing mobilization to the very end and never changed his technique to follow John Shea. all of them refused to recognize each other. Lempert ended up forced to sell his hospital, and then he moved to a small office in 1961. He got into trouble with taxes. He got into depression, and he went into an early form of dementia. He went into an institution in 1963, and he died completely alone in 1968. He never did anyone else's operation, neither the mobilization or a stapedectomy, and he never really discussed anything with John Shea regarding his operation, unfortunately. A memorial service was held for him, and almost all of the surgeons that he trained, including Dr. House, showed up to his funeral. But just a sad way to finish his career because he didn't accept the change. Still, Lempert is a legend, and he was against all odds. He came from a poor immigrant background. He had no formal training. He revolutionized the one-stage fenestration operation. He brought in the dental drill, the loops, the temporal bone lab, and he did some of the first videos of ear, nose, and throat surgery. And he was instrumental in the founding of the Deafness Research Foundation. He really was the father of modern otology, which many people take for granted, or many people don't even know about. Now, stapes surgery has become modified. Now we use a laser. We don't use that Teflon prosthesis that Dr. Shea put together. Now we know that a piston works just as well or even better. Even my former mentor, Dr. Silverstein, has done some select stapedectomy operations by just freeing up the posterior segment of the stapes foot plate with good results. But really, the revolution of stapes surgery was a world effort, which included everyone from everywhere, including the Americas, Europe, and even South America, where in 1934, Dr. Juan Tato, did the first fenestration operation in the New World. So really, what can we learn from all this? I really want the young surgeons to be able to take this story and feel like that, to be innovative, but really also for our older surgeons to embrace change. There's a lot of things that are changing today that maybe it's harder for us to accept. For example, the evolution of otology, of using the microscope, and now we're using the endoscope. There's resistance there, but we really have to embrace change. Change is the only constant. Don't take history for granted. Sometimes when we look at history, we can look at answers for the future. Rosen revived the stapes operation, and he had to look at history to see that. And Shea learned from Lempert and Rosen's obstacles, and he revived the stapedectomy operation. New ideas are always initially rejected. The question is, when we have something new, we don't know which half of these new things are actually good and which half are just snake oil. But you said we still see examples today. For example, using robotic surgery in ENT. There's when it was first came out, there was a lot of resistance with this. And also the same thing with endoscopic ear surgery. We see that today when we go to conferences. There's a lot of resistance from some surgeons to embrace that change of going from the microscope to the endoscope. I'm one of them. I'm also, it's a learning curve, and it's hard to make that switch. But we got to embrace it and really see what's best for the patient and what gives us better results. Don't let your ego get the best of you. Dr. Rosen and Dr. Lempert both had egos, and they didn't change their ways, even to the very end when John Shea was obviously had the better technique. But at the same time, never settle for the status quo. And really, the only thing that's constant is change. And those who change are happy. And again, This is not my story. This is not Lempert's story. This is our story, okay? Across the world, as otologists, this is our story, and we should be very proud of it. There's a lot to learn from it. If you guys want to read the full article, where I talk about more detail about the full history, you guys can find it in the Clinics of North America. If you just look it up, it's a free article. If you have a hard time finding it, just email me and I'll send you guys a copy. Thank you very much. And you can reach me here, WhatsApp. This is my cell phone. You can email me, Nazarian@earsurgeon.com, or this is my Instagram for the young surgeons. But thank you very much. And you know what? Do we have some time for me to show a 1-minute video? I'm gonna play it. This is my patient. He's 95 years old. I've been seeing him for the last 5-6 years. He actually was operated on by Julius Lempert when he was a young boy. And he still remembers to this day the office and how Dr. Lempert was, that he was like a funny looking guy. And it's just interesting to see this 95-year-old talk about this surgery that he remembers still from almost 90 years ago. And I just want you guys to listen. I don't know if anyone else has any patients who had the fenestration operation, but this is amazing.
So we went to see this Dr. Lempert, who had a small hospital. And I finally met this Dr. Lempert, who I still have recollection, he being a very strange individual. That he was evidently not the kind of doctor who would sit down and talk to a patient. He would seem to fit into the room, look into my ear with his miner's light on his head, as I called it. Here I am at the age of 94, have this recollection of this man, this doctor who he was short and never could sit still, and had a strange twitch in one of his shoulders, kept moving around. I guess as a little kid, I kept looking at him, thinking he's a strange little guy who was nervous. Well, I don't recall thinking anything else at that time.
And that's it. Thank you, everybody.
Muchas gracias, Ronen. Ha sido todo un gusto escucharte, porque bueno, además del contenido de la plática, la forma en que tú lo platicas con esa sensibilidad, pues nos mantiene entretenidos, ¿no? De ir como una película, ir viendo qué pasó después, ¿no? ¿Qué pasó después en esto? Que si bien nos gusta la medicina, nos gusta la cirugía, pero todo este ambiente que viven estos personajes o que vivieron estos personajes alrededor de su práctica en la sociedad médica y en la sociedad como tal, en la sociedad común, pues es muy interesante. Estamos acostumbrados a escuchar estos apellidos, pues hoy en día básicamente en las piezas del instrumental quirúrgico que llevan su nombre, que lo que ellos diseñaron, pero no pensábamos en lo que ocurrió o cómo llegaron hasta el momento actual con nosotros, ¿no? Lo que pasó. En esta división que tú haces de las etapas de la evolución de la cirugía del estribo, Pues es muy interesante la primera de ellas, ¿no? Y que bien la llamas, bueno, en general una era preantibiótica, porque ese era el principal problema. Las infecciones, ya sea porque no había manera de esterilizar el equipo, los campos, no se utilizaban guantes, no se utilizaba cubrebocas. De hecho, vemos ahí a Lemper en alguna cirugía pues, sin cubrebocas, ¿no?
Yeah.
No se sabía de esto
Yeah.
de los gérmenes que podían causar los problemas. Y pues siendo una cirugía que abría el oído interno, pues el riesgo de infección del sistema nervioso central era muy importante. Una época sin microscopio y una época donde las comunicaciones eran muy retardadas. Que alguien se pudiera enterar de lo que ocurría en otra ciudad, pues por el telégrafo, por algún tipo de correo que a lo mejor duraba días, o si era a través de un continente a otro, pues duraría semanas, ¿no? Que alguien se pudiera enterar de alguna situación. Muy contrario a lo que hacemos ahorita, que en cuestión de unos segundos podemos estarnos comunicando al otro lado del mundo. En esta parte, bueno, y avanzando un poquito con lo del EMPER, ¿cómo crees que hubiera sido la evolución del EMPER el día de hoy? Si Lemper hubiera tenido el microscopio, hubiera tenido las redes sociales, lo hubiera podido llevar a cabo con su ego, con su personalidad, o hubiera caído mucho más pronto.
Yeah, I think that he definitely, who knows, but maybe it would have been a decline. In today's world with social media, people get canceled even faster, right? So he was canceled by his hospitals. He was canceled by the colleagues initially. And maybe in today's world, I don't know if without a license, without board certification, there's no way he would have been doing what he was doing. He wouldn't be able to have to put his foot into an operating room. So, unfortunately, some of these things that we see, we are so blocked by institutions. We are blocked by bureaucracy. Um, we are blocked even when we want to do research, having approval for research and the ethics and everything else. All these are good things, but in some ways, these geniuses who have these crazy ideas, I think most of the time are blocked before they can even get anywhere. So I don't even know if he would have been able to be a surgeon in today's world to create all these amazing inventions.
Eso es algo muy interesante, que las cosas a veces ocurren por casualidad en el paso de la historia y lo relacionado con la ciencia y con la medicina. Pero para que algo pueda tener realmente una repercusión, tiene que ser la persona correcta, en el tiempo correcto y en el lugar correcto. Si no, si realmente, si esto fuera hoy en día, pues no hubiera alcanzado a poder mostrar lo que fuera. Y si no tuviéramos estos conocimientos previos del manejo de la enfermedad, pues bueno, quién sabe realmente cómo estaría. Aunque, bueno, ese sería un pensamiento con lo que conocemos de la historia, porque seguramente la historia caminaría por otro lado, en alguna otra forma, a lo mejor hasta más rápido que eso. Es muy curioso, bueno, que digo, hoy en día siempre decimos que el maestro y alumno es un binomio que se debe mantener, y habitualmente el alumno debe superar al maestro y lo hace. Aquí veíamos en estas tres fases entre, bueno, los protagonistas, Lemper, Rosen y Shea, cómo fueron ellos, pero bueno, los otros personajes que mostraste que habían visto y que estuvieron con ellos, todos con un ego muy importante, ¿no? El compartir la ciencia en esa época no era algo muy fácil ni muy común. Como nos decías, que obstaculizaba a alguien la visión. Creo
Sí.
que hoy en día como profesores, pues es algo que no hacemos, o en general creo que nadie lo hace, al contrario, queremos buscar el avance de la ciencia. También quizá con ese ego en esta época, pues no hubieran alcanzado el reconocimiento que ellos tuvieron. Y un caso particular también en esto es lo de la cirugía endoscópica. El profesor Muastaravici, eh, que es uno de los pioneros en la cirugía endoscópica del oído, pues llevó sus trabajos desde Medio Oriente a Estados Unidos, y precisamente en el Congreso de la Academia Americana, San Francisco 2011, si no mal recuerdo, pues fue criticado severamente por los maestros de la
Yeah.
otología norteamericana, que rechazaban esta situación. ¿Cómo operar a una mano? Ese era el principal problema, operar un oído a una mano. Y de hecho es una situación que Tarabichi decía que, bueno, pues si todo el mundo me critica, pues es que tengo que abandonar esto. Sin embargo, fue constante, y bueno, la cirugía endoscópica de oído ha tomado su lugar en algunos procedimientos, no en todos los procedimientos otológicos, en algunos como instrumentación única, en otros como colaboración con el microscopio, y en otros solamente para revisar, ¿no? Para observar lo que vemos por ahí. Y esa pudiera ser la similitud de esta historia de Lemper en el mundo actual.
Yeah.
No sé si Erika, Mónica, quisieran
Yeah.
comentar algo.
My my
Adelante,
goal
Ron. Sí.
for this talk is really for everybody to have a little bit of Lempert inside of them. And for that exact reason, when you come on the podium and you present something or you have an idea, and and most people say you're crazy or this is not going to work, hold that Lempert inside of you and remember that story, because sometimes you might be really wrong, but other times you might be right and you have to persevere. And just like John Shea was able to find the collaboration with Dr. House, who was already an established figure, and Dr. House became a mentor who helped him get the word out. I think that's also important for us, especially the young innovators of today. We need to have good mentors who can bring us through the door. And I think we have to have a little bit of Lempert inside of us to remember that it's always an uphill battle. There's always going to be critics who are not going to think that you are correct. And the problem is that I think it's 50-50. 50% of this stuff sometimes isn't correct, but 50% is. Which one is it when we listen to it? We don't know, but only time will tell. All right. And for a lot of these younger surgeons, time is on their side. And I would say just hold a little bit of Lempert in your heart and remember to persevere.
Y también, doctor, muchas felicidades. También, pues William House enfrentó a una gran negativa. Creo que cuando presentó sus resultados del implante coclear, debería ser una plática justo de la historia del implante coclear, porque también hubo muchísimos detractores, ¿no? Creo que justo esa vez, no sé si me escucha, esa vez de cuando sucede que presenta lo de implante coclear, tengo entendido que lo corren del podio o algo así, una negativa así absoluta sobre el implante coclear.
Oh yes, I have another presentation
Ujú,
where I talk about the cochlear implant history, and it's the same exact thing.
ujú.
So hopefully one day I'll have the honor to be invited again and I can give you guys
Sí.
the cochlear implant history that also has videos and stories about what those pioneers had to go through, and it wasn't easy. And I remember my mentor almost got into a fist fight with another
Wow.
doctor. They were at the academy, and they presented the cochlear, and then they went to the bar, and my mentor, Dr. Silverstein, told another doctor who was a chairman of a big institution. He said, you know, this cochlear implant thing is amazing. This is going to be revolutionary. What do you think? And the other doctor just said, buzz, 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 buzz. And every time he tried to say something, the other doctor said, buzz, 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 buzz. And they almost got into a fist fight at the bar because he wasn't saying buzz, buzz, buzz. That he wasn't believing that the cochlear implant was going to work.
Qué impresionante que eso suceda y que los mismos alumnos dejen de, pues, de aprender. La historia del Lemper me impactó el hecho de que haya muerto como lo hizo con esta depresión y con esta demencia. ¿Por qué sucedió esto? Por qué cree, doctor, que Lemper llegó a esa parte de su vida siendo él tan próspero y teniendo tantas ideas? ¿Por qué habrá llegado a ese punto en el cual tuvo esa muerte, que él muere solo en un asilo?
I think really back then medicine was different. And we know that because medicine was all about ego. If you look at everything around you that was discovered more than 50 years ago, it has some man's name on it. Okay. From the instruments that we use and to everything, it has a man's name. Someone put their name on it. So it was always about ego for more than 100 years, or maybe for 200 years. It was all about ego. It was putting your name on whatever body part you discover and whatever disease you discover, and maybe it attracted people with egos, because in a way, once you discover something like that, you almost become like godly, right? When you discover a cure, or you discover an operation that saves someone's life, or saves a big sensory problem like hearing loss, you back then they became like gods. They were superhuman. And you know, and that's different now. You know, we don't do that anymore. Now when someone tries to put their name on something, it's looked down upon. It's not as accepted. So there's less ego in medicine. And I think that, you know, that's maybe why he died alone, and because he never came out of that. That was his personality. That's who he was, and he became this big personality. You know, when his operation, when he went against all odds and became world famous, basically, it's hard to let that go, and we see that today. Maybe not in medicine, but we see that today in politics and other situations. So maybe those people with the big egos are doing some other things now. They're not going into medicine. Medicine is a very humbling field these days.
Muchísimas gracias por la plática. Realmente fue encantador ver los videos. O sea, verlos hablar, verlos platicar acerca de lo que lograron hacer es increíble. Y el último video del paciente es fantástico, ¿no? O sea, cómo él describe esa personalidad y esa esencia de esa persona. Y cómo después de muchísimos años recuerda la esencia de la persona, realmente fantástico. Aquí tenemos a un doctor mexicano, el doctor Narváez también platica que él tiene una paciente de 90 años que fue operada y después recibió otra cirugía y bueno, no, o sea, creo que habla también de agradece el video y habla tuvo excelentes resultados con la discriminación y bueno, o sea, más bien le diríamos al doctor José Narváez que tome un video y no lo comparta, porque realmente es increíble, es fantástico verlos.
Yeah, it's I'm glad you love that video because I really love that patient. And the video is much longer. He talks about the hospital and everything else that he remembers from the surgery. But really, the other reason I love the video is because it makes you think, what is someone going to say about you in 80 years? You know? So we should be careful in a way, because we think it's just another patient. To them, we might be their only doctor, and this person remembers. So I really wonder now, what is a kid that I'm taking care of now? What are they going to say about me 80 years from now? I'm not going to be around. So these patients are going to be defending my legacy in a way.
Claro. Bueno, otra cosa que me quedé pensando es, si tengo bien los datos, el doctor House también terminó con problemas económicos al final de su vida. Entonces, habla de que los médicos que hacen grandes avances, pues también tienen que cuidar sus finanzas, ¿no? Porque al final del día hacen aportes a la ciencia y hablando ahorita de, pues, de todos los jóvenes que están trabajando, todos los que vienen, cada vez la economía es un poco más compleja y definitivamente el retiro para todos es muy importante, ¿no? Y a pesar de que puedas crear cosas inauditas en la ciencia, pues nunca hay que dejar atrás pues, el cuidar a la familia y pues, el legado financiero que puedas dejar para cuidarte en la tercera edad, ¿no?
Yes, that's very true. But also, Dr. House was a very special person because he was a gentleman and he didn't have an ego. And he died with less money because the cochlear implant, they decided not to have a patent on the cochlear implant. He decided that the cochlear implant belongs to everyone and it belongs to the world. And he did not take a patent when they put it out there. They worked with the company 3M, and he specifically said that the cochlear implant is for everybody. And he didn't take a patent on it. He could have been very, very rich, and he didn't take a patent on it. Yeah.
Impresionante, ¿no? No sabía.
Pues qué cosas interesantes. Seguramente podríamos pasarnos muchas horas, muchos días hablando de diferentes aspectos en la evolución tan solo de la otología, más aún de la otorrinolaringología, pero tan solo de la otología, con estas cosas que hoy podemos vivir, que hoy podemos ofrecer a los pacientes. Realmente esos antecedentes de Lempert, de Rosen, pues han permitido que la cirugía de Shea prácticamente hoy en día es la misma que se hacía desde hace 70 años, con algunas variaciones tecnológicas, pero esa, bueno, es la que ha llegado a quedarse. Y en esto que tú mencionas dentro de 80 años, pues sí, tal vez el paciente esté tomando una pastilla con la cual sea capaz de que diluya la formación otoesclerosa que tenga el paciente y tal vez para evitar una secuencia hereditaria, pues entonces le dan alguna otra enzima o algo al familiar para que no desarrolle la enfermedad, ¿no? Y pensarían que éramos unos locos por estar abriendo el oído medio, el oído interno, para reparar estas cosas, ¿no? Es la evolución que tendrá la historia
Yeah.
y a lo mejor pues seremos criticados en un siguiente tiempo. Si tuvieras que escoger una característica de Lempert en cuanto a las cosas que puso en la otología o en la otorrinolaringología, ¿crees que sería la introducción de la lámpara frontal, la introducción de la fresa, la fenestración, su habilidad quirúrgica o su tenacidad? Si pudieras escoger uno de ellos, ¿cuál crees que es la mayor característica de Julius Lempert?
If I had to pick his greatest character, it would be his innovation. That despite all odds, he was still able to create all these different tools and techniques, despite everything that was going against him. So it was his innovation and perseverance. But if I had to pick one tool out of the many things that he was famous for, I would say the drill, because really, until today, we're still using it. It's not the exact drill of the dentist, but I mean, that was the most revolutionizing thing that we still use every day today as otologists. The drill is our most important tool. So, when it comes to the mastoidectomy, that has not changed, and really Lempert had a vision there, and I hope that it will be remembered for that.
Pues ha sido una noche muy, muy interesante. Tenemos muchas felicitaciones por tu presentación de nuestros asistentes. Ha sido un gusto tenerte con nosotros. Bien dicen que la historia hay que conocerla para no repetir los errores que se han cometido y para aceptar lo bueno, para poderlo continuar, si no, pues volveríamos a pasar por lo mismo. Tú ponías la frase de que el cambio es constante y hay que cambiar con él. Eso es importante para que el hombre pueda seguir evolucionando, como ha sido todo a través de la historia. Agradecemos mucho a nombre del Colegio Mexicano de Otología, Neurotología y Cirugía de Base de Cráneo que hayas aceptado estar con nosotros. Esperemos volver a verte por aquí, poder compartir contigo en alguna situación en persona, tal vez ahora en la Academia Americana en Miami podamos saludarnos personalmente. Agradecemos mucho la invitación que has hecho para que los médicos mexicanos puedan visitarte en Los Ángeles. La situación es que es en Beverly Hills, no es cualquier cosa en Los Ángeles. Y por lo que platicábamos el otro día, la clínica donde tú laboras está en Rodeo Drive. Y quien conoce eso es una de las calles con las tiendas comerciales más caras tal vez del mundo, o una de las más caras del mundo, ¿no? Con lo que está por ahí, entonces hay que ir preparados para poderte visitar por allá. Nuevamente, muchas gracias, Ronen. Muchas gracias a mis compañeras, la doctora Erika Celis, la doctora Mónica Rodríguez, por siempre acompañarnos en estos eventos, a los asistentes por estar con nosotros. Estén pendientes de nuestra próxima sesión. Como saben, habitualmente es el último jueves de mes. Sin embargo, el próximo mes, en marzo, coincide con la Semana Santa, con el Jueves Santo, de tal manera que es una fecha vacacional, entonces ajustaremos la fecha, ya les estaremos informando como lo hacemos por nuestra forma habitual. Muchas gracias nuevamente, un gran abrazo, Ronen, hasta Los Ángeles, que estén muy bien todos y muy buenas noches.